Hello everyone, welcome to this Thursday's webinar. Today's subject will be the recent progress in the treatment of lower risk myelodysplastic syndromes, presented by Professor Pierre Fenaux of the Hôpital de Paris Saint-Louis and the coordinator of ERN-EuroBloodNet. Before starting the presentation today, I would like to go through some of the housekeeping notes. Please note that your microphone will remain muted during the presentation. Please also note that this webinar is being recorded. You can submit your questions via the Q&A chat at any time. The Q&A session will follow directly after the presentation. Please also note that this program is accredited by the European Board of Accreditation in Hematology. You can earn 1 CME credit per webinar attended. In order to do so, please attend the full webinar, complete the feedback survey at the end, have an active EBA account, and use your EBA email in the survey. Further instructions will follow after the event. So with that, I pass the floor to Professor Pierre Fenaux. The floor is all yours. Thank you very much.
So good afternoon, and my topic today will be on lower risk MDS, but in fact I will focus on treatment mainly. So just first, what is lower risk MDS? So the classification, the prognostic classification of MDS is mainly made based on the International Prognostic System revised, so IPSSR, which is based on chromosome cytogenetics, marrowblasts, and cytopenias, hemoglobins, platelets, and neutrophils. And so generally, I mean, so this allows to classify patients into 5 groups, from very low to very high, and generally what is considered as a low risk MDS is having a revised IPSS below 4. So that is patients being low, very low, or intermediate, a part of the intermediate patients. And in those patients, while in high-risk MDS, the main purpose is to avoid progression to acute leukemia and improve survival, which is generally short. Here, one of the main objectives is to improve cytopenias, mainly anemia. So, but this IPSS-R was designed before we knew most patients had somatic mutation in their marrow cells, and actually almost all MDS patients have mutations, so that having no mutations is often means it's not MDS. And what is typical of MDS are mutations in splicing factors like SF3B1, SRSF2, methylation, chromatin modification. The other ones are less typical, and in particular, some are like NPM1, FLT3 are mainly for acute leukemia, and JAK2, calreticulin, and MPL for myeloproliferative neoplasms. So what is really typical is splicing factors, methylation, from chromatin modification. And so a new prognostic classification has been designed using 16 genes, and there's a list here in brown, and those are genes that allow to classify prognostically patients, in particular, and allows them to be classified into 6 groups. And the addition of mutations modifies the classification of patients, in prognostic classification of almost half of the patients. So some are upgraded by mutations and others are downgraded. On the other hand, now most treatments have been approved based on IPSS revised. So the molecular data may not be always necessary, but perhaps let's take the ones that are most important. SF3B1, because it's a marker of sideroblastic anemia, and MDS with ring sideroblasts, and when alone or with favorable mutation like TET2 is associated with good prognosis and almost never progresses to acute myeloid leukemia. By contrast, TP53, especially when it involves both alleles, which is called biallelic, is associated with very poor prognosis, but is generally not seen in lower risk MDS. Now, IDH1, IDH2 mutation are important because they can be targeted. FLT3 mutation, as I said, is rare in MDS, is more AML, but it can also be targeted. So those are the important ones for from a prognostic viewpoint or therapeutic viewpoint because of the possibility of targeting having targeted treatment. So now, what is more important, as I said, in low-risk MDS is generally anemia. Now, thrombocytopenia in some patients can predominate, but it's generally anemia. And there are two ways of treating anemia. One is to try to improve the hemoglobin level and avoid transfusions. That's the blue line. And one is to transfuse patients. And so if you transfuse patients, as you can see, the hemoglobin level oscillates and because when it increases when you transfuse patients, and patients spend at least half of their life below 8 grams of hemoglobin. And there is an important curve. It's possibly the most important slide in my presentation, which correlates the hemoglobin level to the quality of life. It's a sigmoid curve. So you're much better when you're at 11 or above, as opposed to 9 or less, especially less than 8, where you're tired, especially in elderly patients, and we know MDS predominate largely in elderly patients. So how to treat anemia? Well, we have first what is called erythropoietic stimulating agents like EPO and darbepoetin, and those are used mainly in patients who have no del5q chromosome abnormality. About 50% of the patients will respond with a median duration of about 2 years. The other first-line treatment can be lenalidomide in patients with del5q, so 5q deletion. About 65% of transfusion, red blood cell transfusion independence, and half of them achieve a cytogenetic response. That means there's a disappearance of the 5q deletion clone with a median duration of slightly above 2 years. Second-line treatments will include so those are relatively well-known treatment. Second-line treatments will include immunosuppressive drug, like it's mainly anti-thymocyte globulin, associated with 40% response also. But this is a highly selected population of generally relatively young patients with no excess of blast, normal karyotype, etc. Lenalidomide can also be used in non-del5q patients. Modest transfusion independence rate of 25% also. Median duration relatively short, for about 8 months. And hypomethylating agents do not work very well in this situation. This is mainly an azacitidine, which is mainly the treatment of high-risk MDS. So this is the background. And so let's see how can we improve things. First, lenalidomide, can it be started earlier? Because normally it's approved in case of transfusion-dependent anemia. And so we conducted with our Spanish colleague a trial where moderately anemic patients, that is hemoglobin below 12 grams, who were not red blood cell transfusion dependent, were randomized between lenalidomide or placebo. And the response rate was high, 72% with lenalidomide, and of course 0% with placebo, with a good cytogenetic response. And apparently the treatment was capable of delaying time to transfusion dependence. So it may be from 11 months to 66 months. So perhaps lenalidomide could be used earlier in the course of MDS with 5q deletion, although it's not yet approved in this situation. Other possibility is to use for second-line treatment lenalidomide in patients without 5q deletion, so it's a situation where it's not approved. And we found that in those patients who are resistant to EPO, lenalidomide plus EPO did better than lenalidomide alone. So that was a randomized study. And as you can see, the response to the combination was 52% as compared to 30% in lenalidomide, with lenalidomide alone. So it's a good second-line treatment to which approximately half of the patients will respond. Now, so those are the existing drugs, but until recently. But of course, most patients, as you can see, will eventually resist to those treatments and become red blood cell transfusion dependent. So many other drugs have been tested, and the ones I'll just highlight the results obtained in the ones in blue, and the other ones have either have just started or are disappointing. So among the ones in blue, I will not detail IDH1 or IDH2 inhibitors. They work pretty well in this situation, but those mutations are seen mainly in patients with high-risk MDS or even acute myeloid leukemia. But they work in this situation. But once again, those mutations are quite rare in lower-risk MDS. So let's see the other drugs. First, there's roxadustat, which is a HIF hydroxylase inhibitor, which led in a phase 2 study to transfusion independence, TI, in 37% of the patients, which is not too bad. Those were patients who were resistant to EPO. Unfortunately, in a phase 3 trial, it did not show significantly better results than a placebo arm. And one of the reasons, I have no time to go into details, was that the study was not very well designed and that the response rate in the placebo arm was 30%. So it's difficult to do better. And for this reason, unfortunately, the drug has been abandoned. So this highlights and this stresses the importance of properly evaluating response criteria, which I have no time to detail here, but we have new response criteria that may improve the evaluation. So after that, we have imetelstat, which is a telomerase inhibitor, which in a phase 2 study on 38 patients showed, who were highly transfusion dependent, showed transfusion independence in 42% of the patients with a median duration of 85 weeks or so. And results were confirmed in a phase 3 trial published now in the Lancet, iMerge, which randomized imetelstat, this is the drug, imetelstat every 4 weeks, and placebo in patients who are resistant to EPO and who are transfusion dependent. So it's important to have a placebo, of course. And those are the patient characteristics: highly transfusion dependent anemia. And this is the response rate: 40% transfusion independence with imetelstat and 15% in placebo. You can see with placebo, it's not a true response rate, but it's just because the response rates were inadequate at the time. Also, some clinicians include, kind of over-transfuse the patients before inclusion in a trial to be sure the patient can be included, etc. So it's always important to have a placebo arm. But here there's clearly a difference, 40%. And the response duration is also more important, with a median of 52 weeks. And of course, the placebo response is quite short. And one problem with this drug is that it leads to transient cytopenias during the first infusions. That is neutropenia, thrombocytopenia, which can be of concern, of course, in patients in elderly patients. It could lead to infection or bleeding. And what is interesting is that indeed this drug, sorry, there's a problem with the slides here, but it reduces the clonal size of treated patients. That is the variant allele frequency of those mutations. It's a 3B1, TET2, DNMT3A, ASXL1. So showing that it has an impact on the clone, contrary, for example, to EPO, that does not have an impact on the clone. And this could explain, by the way, the initial cytopenias. So it could be a drug with potential interest in the long term, because it may slow disease progression because it has an impact on the clone. So this is the telomerase inhibitors. So the drug is approved at the European level, but is not always available. For example, in my country, in France, it's still not available because after European approval, it has to go through other agencies, etc., before it's approved and reimbursed for in daily practice. The second approach after telomerase inhibition is TGF-beta inhibition. TGF-beta is a pathway which in the red blood cells overall inhibits erythropoiesis, especially through ligands like GDF11, activin, which act on activin receptor, especially activin receptor 2. And this can be inhibited, this pathway, and particularly by drugs that will be capable to track the ligands like luspatercept or sotatercept. So sotatercept has not been developed in this situation, but luspatercept has. So it's an extracellular domain of the activin receptor, which is going to capture the ligands of this domain and an FC domain okay. And so what is interesting is that luspatercept acts late in erythropoiesis, that this is to inhibit the TGF beta pathway, whereas EPO, as you can see, acts earlier in erythropoiesis. And that gives already the idea that the two drugs could be combined. So the effect of luspatercept was demonstrated in a phase 3 trial, once again randomized, luspatercept versus placebo, in patients who are resistant to EPO. And those were patients with MDS with ringed sideroblasts, those patients, as I showed before, who have the SF3B1 mutation. And so I'm not going to go into detail. Once again, 15% response in the placebo arm and 47% response in the treated arm. And so a clear advantage. And I'm not going to go into details. 80% median response duration in the luspatercept arm. And as you can see, the response in placebo is not a real one. You have including durable responses, which do not correspond really to responses. And the disease, as you can see, rarely progresses to acute myeloid leukemia, so 5%, and only in patients who in addition to SF3B1 have deleterious mutations like RUNX1, ASXL1, etc. So it's important to monitor those mutations for follow-up to be sure that those patients do not have a risk for progression. So in those patients, really, what matters is anemia rather than progression to acute myeloid leukemia. Okay, what are the perspectives with luspatercept? So combinations with EPO, combination perhaps with the other effective drug, lenalidomide, and use in MDS without ringed sideroblasts. So those are the trials I'll detail, especially in first-line treatment, etc. So first, this trial, which is a trial led by the GFM, the French MDS group, which is a trial sponsor, that compares luspatercept and luspatercept plus EPO in patients who are resistant to EPO and who are not, who are ringed sideroblast negative. So here we would like to reproduce what we saw with lenalidomide, which in combination with EPO was better than lenalidomide alone in patients resistant to EPO. And now, so that was the first. Now, the drug has been used for first-line treatment in low-risk MDS, irrespective of there being ringed sideroblast positive or negative. That is the COMMAND study, which is now published in the Lancet. That was a presentation which compared luspatercept and EPO in patients who were treatment naive, but who had red blood cell transfusion dependence. And mainly the primary endpoint of the study was red blood cell transfusion independence. And as you can see, it was achieved in 58% of patients with luspatercept and 31% of those treated with EPO. Now, there was an advantage for luspatercept in patients who had low or high serum EPO baseline level. Also, depending on the transfusion requirement. But the main issue is that the difference is very significant, 65% versus 26% in patients with ring cell blast, whereas RS plus, whereas in RS negative patients, as you can see, there's no obvious difference. And well, of course, this is reproduced by SF3B1 mutation, which is equivalent to the RS ring cell blast status. And so this, I mean, transfusion independence. So clearly the results overall are better. The results also are response is longer with luspatercept than with EPO in blue. And now also irrespective of the serum EPO level. And for RS plus, this is ring cell blast, there's clearly an advantage in terms of treatment duration for luspatercept, whereas in RS negative patients, the number of patients is small, it's difficult to conclude. The problem with this trial is that majority of patients were ring cell blast positive. So it's difficult to conclude in ring cell blast negative patients. Now, so following this treatment, the drug has been approved at the European level, EMA level, and also, like for imetelstat, it's used in the level of each country. Its reimbursement are discussed, and we don't know, for example, if at the national level some countries will perhaps approve the drug for ring cell blast positive patients, but not for ring cell blast negative patients. Obviously, also because it's a new drug, it's more expensive than EPO, so it may also be a criterion used for countries to reimburse or not. Okay, so then I will go to chelation therapy, because what happens, and I will go back to thrombocytopenia after, what happens is that in spite of those treatments, many patients end up being transfused very regularly. So transfusion leads to accumulation of iron, which saturates the binding proteins and it goes to various organs. First the liver, but then the heart and also the endocrine organs. But it goes relatively rapidly in the liver with relatively limited damage or moderate damage, and the most important damage probably for the heart. And it rapidly infiltrates the liver. For the heart, it's slower. So you need, generally, as you can see here, you really start to have a frequent cardiac infiltration after 70 to 75 concentrates. This is so a relatively long term. And so patients, especially with sideroblastic anemia, who can be transfused for years, may unfortunately have this overload unless you prevent the iron overload. And the best way to assess the cardiac overload is by MRI, which measures the T2 star. And when the T2 star is below 20 milliseconds, then the risk of cardiac overload and therefore of cardiac failure is quite high. And so, and also, it has been shown that, for example, after transplant, bone marrow transplantation, having an even moderate cardiac overload was associated to lower survival in orange, which was not due to a higher risk of relapse, but to more transplant-related mortality, because probably of toxicity of free iron in the body. And so there are some drugs to reduce the iron overload, and the main drug is deferasirox, which is an iron chelator, and it's been shown in randomized trial that if you compared treatment between deferasirox and placebo, you had a better event-free survival, probably improved by something like 30%. And so this drug is important, and it should be started when the ferritin level, because that's the way to assess iron overload, in addition, of course, to MRI, but MRI cannot be repeated every week or every month. And so when the ferritin level increases above 1,000 to 2,000, then chelation therapy should be started, especially in patients who have a favorable prognosis, who could be transfused during 10 years or so. Okay, and in some cases, deferous irox can moderately improve cytopenia, so it's a double interest. Okay. Thrombocytopenia, as I said, thrombocytopenia is rarely the first cytopenia in low-risk MDS, but it can. And in this situation, TPO agonist receptors like romiplastin can improve platelets in half of the patients. But this drug can also transiently increase blasts in 15% of the patients. So it is contraindicated when there is initially at baseline an excess of blasts above 5%. Okay. And eltrombopag is the other one, which also, this was a randomized trial where 42% of the patients responded to eltrombopag. So it's also a drug that can be used in those patients when there's no excess of blast. And this is a study we conducted in France with 77% response to eltrombopag. So those drugs can be interested when there's important thrombocytopenia, especially with bleeding, of course. Okay. Now, I'd like to conclude by the combination of MDS with autoimmune, auto-inflammatory disorders, which is it will not be my conclusion. There will be another chapter. About 20% also of MDS or chronic myelomonocytic leukemia, which is a disease which is close to MDS, are associated to what I called SIAD. This is systemic inflammatory or autoimmune disorders, for reasons that are unclear. Their prognosis is not different from that of isolated MDS. What we found was that those patients had often mutations in IDH1, IDH2, SRSF2, in some TET2, in some specific mutations. And interestingly, those mutations, when they are seen outside of MDS, what we call clonal hematopoiesis, that is mutations at a low variant allele frequency without cytopenias, can lead to inflammatory disorders and to even cardiovascular disorders. So our hypothesis is that the mutations lead to both MDS and to autoinflammatory or autoimmune disorders. And we found indeed that azacitidine, which is a major drug for MDS, rather, as I said before, the high-risk forms, but was associated to response in those patients who had both MDS and autoimmune disorders on both diseases. And this is a small series, but it was confirmed by, retrospective, it was confirmed in a prospective series. And recently, in Blood, we published a larger series of close to 90 patients, showing once again a high response rate to azacitidine, both on MDS and on the inflammatory or autoimmune disorder. Now, in the same chapter, I would say, there is a disease which is called VEXAS, which is due to UBA1 acquired mutation, and which leads to, it's an autoinflammatory disease with cutaneous lesions, in particular, systemic clinical abnormalities. It is X-linked. It leads to vacuoles in granulocytes, and about 40% of the patients have concomitant MDS. And so, and this is always low-risk MDS. So when you have low-risk MDS, especially in males, it's important to test this mutation, UBA1 mutation. What we found was that JAK2 inhibitors like ruxolitinib worked pretty well in VEXAS. And as I said before, azacitidine also works pretty well in VEXAS with or without MDS. So it's important to know if the patients have VEXAS to treat them with azacitidine or, for example, JAK2 inhibitors to improve cytopenia. Generally, after first treating the patients with steroids. Okay, now perhaps the last issue is whether a transplant should be proposed to some patients with low-risk MDS. As you know, bone marrow transplantation remains the only potentially curative treatment in MDS overall. So it's clearly indicated in high-risk MDS, where we know it improves survival, and it has been demonstrated in prospective studies. What about lower risk MDS? The issue is always the same. I mean, a transplant, bone marrow transplantation is associated with early mortality. Another problem is that many of the published data include patients transplanted 10, 15 years ago with a relatively high mortality. Now, mortality has improved after transplant because of better matching between donors and recipients, and also because we've improved the prophylaxis and treatment of infections which follow transplant, because transplant is associated with protracted immune deficiency. And so reducing infections has improved outcome. But for example, in this series, you see that there's an early mortality of about 30%. So it's difficult in a patient with low risk MDS to suggest transplant, because, you know, this patient is going to would with MDS have had a more prolonged survival. Now, but even what is important is that MDS patients have a median age which is relatively high. I mean, it's a rare disease below the age of 60. And this is two more recent clinical trials led by the GFM, so recently published. So it's not, you know, data from 15 years ago. And as you can see, the median age was 62% in the two series, and the transplant-related mortality was 17% and 19%. So because this is an elderly population, and we know transplant is associated with a higher mortality in the elderly, it remains difficult in MDS. And we transplant patients up to 75 in several situations. But you can see that in lower risk MDS, it's obviously problematic. And so we have to be restrictive and think twice before we go to transplant. So, well, this is a series showing, for example, that, you know, 19% transplant-related mortality in one trial. Okay, so to be very, to try to have clear ideas, I would say that a patient with what I'd call RARS, which is sideroblastic anemia, with normal karyotype and isolated SF3B1 mutation, or SF3B1 mutation, for example, plus STAT2 mutation, will probably never progress to AML, or at least not before acquisition of other mutations. So this patient, unless he or she is transplanted very frequently and is relatively young, below the age of 50 to 60, I would not transplant. And I would say it's better to be transplanted, to be transfused every 2 weeks than to die, to be schematic. By contrast, a patient who shows progression, who acquires a TP53 mutation with a variant allele frequency of at least 20%, which increases. If a patient who does not respond to first-line treatment, like del(5q) failing lenalidomide, then this patient has a poor survival and should be transplanted whenever possible. Now, we used to say if there's a donor, but now almost everyone has a donor, because we use either HLA identical brothers or sisters, or unrelated donors in the from the international registries, but now we more and more transplant patients with their children. And so overall, at least 90% of the patients have a donor. But of course, they need to have no contraindication due to comorbidities, etc. But so, and in other patients, therefore, this has to be really weighed. Age, comorbidities, the donor, because, for example, having an unrelated donor, which is matched only 9 out of 10, is less good than matched 10 of 10. Response to previous treatment. When a patient responds to a treatment, it means that this patient is not going to progress rapidly. So you should probably continue on treatment. The importance of cytopenia, of course, if you have severe thrombocytopenia with bleeding, of course, you may be inclined to transplant the patient. Mutations, mutations per se are rarely an indication for transplant, except perhaps TP53. But otherwise, we lack follow-up to say that we're going to transplant a patient just based on mutations. Progression, of course, and of course the patient choice at some point. And so this is a difficult decision to take, but it's rarely urgent. So you can wait and see if the patient evolves, etc. So okay, so I'd like to conclude by acknowledging the services of the department I'm part of in Paris. I mean, which includes the hematology services in Hôpital Saint-Louis for adults, Robert Debré for children, Avicenne for adults also, and the French MDS group, as I said, which is mainly a French group which sponsors clinical trials in France. And we work with other groups, especially the Italian group, German group, a Spanish group, through a group which is called EMSCO. And of course, there's EuroBloodNet, which also can sponsor trials, activate registries, and provide, when possible, a transborder medicine to allow access to diagnostic procedures and new treatments, and also education for professionals, and especially through webinars like this one, through preceptorships, that is short stays in specialized centers, and you are quite welcome. We organize some, 5 or 6 persons coming for a week or 2, and therefore with courses, but also clinical practice, and that's it. And just to also advertise this European School of Hematology session on MDS. We work at EuroBloodNet in cooperation with the European School of Hematology and also the European Hematology Association on many of our activities. So thanks a lot, and I'm available for questions.
Thank you very much, Professor Fenaux, for your presentation. Very comprehensive. I think that we have one question from the participants, from Mona. What are the precautions for luspatercept treatment in MDS, complications or treatments?
So luspatercept sometimes have side effects, which is there are many two. One can be dizziness for reasons that are unclear, which is, of course, problematic in those patients. And the other one is a kind of fatigue, which is different from that of the fatigue induced by anemia. But of course, it's a problematic. If you improve anemia, that is fatigue due to anemia, and provoke another type of fatigue, it's problematic. It often improves with if you continue treatment, but it occurs in about perhaps 20% of the patients, but some have to discontinue treatment. Yeah. So those are the main side effects. Yeah.
I think that we don't have any other question.
No other questions?
If anyone has another question, please, you can write it down in the chat box.
Yeah, and later you can email to one of us, and we can easily respond.
After that, yeah, sure.
Okay.
Okay.
So thanks a lot indeed.
Thank you, Professor Fenaux. I think that giving us an announcement at the end of this webinar to make. Thank you.
Thank you very much, Professor Fenaux, for your excellent presentation. It was quite clear and one of the best that we've seen all year. Just real briefly, I would like to announce our upcoming Thursdays webinar that will take place on October 30th. I put that in the chat, as well as the link where you can register for the individual session. The topic will be the update and treatment of AL amyloidosis and monoclonal gammopathy of clinical significance. That'll be at the same time, starting at 5 o'clock, and speaker will be Professor Bertrand Arnaud. So if you have the opportunity to register, we look forward to seeing you then. You can also access our website to find out the upcoming Thursday webinars, as well as our topic on focus webinars and the multitude of educational webinars that we offer at ERN-EuroBloodNet. So on behalf of ERN-EuroBloodNet, of which we have our coordinator here, Pierre, I would like to thank you for joining today, and we wish you a wonderful afternoon and evening. Thank you very much.
Okay, thanks a lot. And once again, available for any cooperation on the topics I stressed, like registries, clinical trials, discussion on guidelines, transborder health if there is any need, etc. So we are really available and for any cooperation. Thanks a lot. Bye-bye.